hand it over to you, Dr. Evison.
Thanks, Jackie. Okay, so updates to the ADA standards of care. There's going to be a lot of things that I talk about today, and I may get a little bit into the weeds during the presentation. I think it's important to acknowledge that in primary care, we have been doing a lot of this work already, and the ADA is catching up to us. There might be some details here that are food for thought or might make you think a little bit more about one subject or one resource that you're not thinking about already. And that's how I would approach this presentation. That's the ultimate goal, just to make you think a little bit more about some things for our patient care. Our objectives today, we're going to focus on the algorithm, which will be the next slide. And there are 3 important updates to the algorithm about using diabetes education, MASLD and MASH, CKD updates. And then there's going to be some rapid fire updates from the standard of care at the end of the talk. Throughout the presentation, I will zoom in on key important insights in the algorithm. This is the whole picture. You don't need to memorize it or anything like that. It's very similar to last year, but again, there's those 3 important updates. So we're going to start with a case. This is Maria. She's 52 years old. She's coming in for a diabetes return visit. And during the visit, she reports decreased energy levels. Someone with diabetes, right? Something that we should be thinking about more, or a term that we should be becoming familiar with, is this term of diabetes distress. Diabetes distress is the emotional distress related to the demand and burden of diabetes management. It not only affects our patients, but it may also affect caregivers and family members. There are a lot of behavioral demands on our patients with diabetes, with having a diabetes diagnosis. They have to think about their medications, their dosing, frequency of their dosing, the titration of their medications. They're monitoring their glucose, lifestyle management, their food intake, their eating patterns, physical activity, their sleep, the potential or actual disease progression. Some common triggers that can lead to diabetes distress includes meeting blood glucose targets, fear of complications, and struggling with self-care routines. Studies show that between 45 and 60% of people with diabetes struggle with diabetes distress. That's a lot. And we don't often screen for it. Many of us might be screening for depression and anxiety, and I think that should count. Especially we're doing this with our medical wellness visits and health maintenance exams. I think this can be a surrogate for diabetes distress. Seen here on the right is the PAID scale, which is a diabetes-focused questionnaire. There are 20 questions in this questionnaire. A score of 40 or more is considered severe diabetes distress. This is the survey that the ADA recommends for diabetes distress. Again, that would be a lot to add to our practice. The ADA update recommends screening for diabetes distress annually and to repeat screening if treatment goals aren't being met in the presence of new diabetes complications or during transition times in their care. In my practice, I plan on having the idea of diabetes distress in the back of my mind more frequently, especially when goals are not being met or when they're having new complications. So this leads to our first algorithm update, utilizing DSMES more frequently. If you have concerns for diabetes distress, we can utilize our diabetes self-management education and support teams and or refer to mental health professionals. The algorithm has changed from consideration of DSMES for patients to recommending all individuals with diabetes utilize DSMES. DSMES empowers individuals with diabetes by providing them with the tools to make informed self-management decisions and helps take some of the burden off of our plate. Studies show that DSMES improves diabetes knowledge, glycemic control, and weight, and reduces all-cause mortality. It lowers healthcare costs, it reduces hospitalizations, and it improves quality of life. And it does this all by empowering our patients. We should be offering DSMES at time of diagnosis, annually for assessment of educational needs, and when they have new complications, or during transition times. So back to our case, Maria. Given her fatigue symptoms, you decide to order some labs to rule out other causes of her fatigue. You check her thyroid, her blood counts, you get a comprehensive metabolic panel looking at kidney and liver function. You order lipids and an A1C. I'm going to give you like 15 seconds to look at these labs. I want you to see if there's anything that sticks out to you. Jackie, can you activate the poll?
Yes, I can.
So I'm curious to know what your answers are. When I see a patient with type 2 diabetes, even with normal liver enzymes, I calculate a FIB-4. Never, rarely, sometimes, or always.
We'll give people about 30 more seconds to respond. We have about half of the people having responded so far, Dr. Gabison.
Great. It gives me time to take a sip. Okay, let's see what the results are.
Okay, I'm ending the poll now, and everyone should be able to see the results.
Yeah, so 54% of you say never, 23% say rarely, 19% say sometimes, and 4% say always. Okay, so FIB-4 is a screening tool for liver fibrosis, and it uses age, AST, ALT, and platelets. Maria's FIB-4 score is 1.74. Getting back to the algorithm, there's a new section highlighted here in red on MASLD and MASH. It highlights specifically the importance of mitigating the risk of MASLD or MASH and introduces treatments with potential benefits. MASLD stands for metabolic associated steatotic liver disease, and MASH stands for metabolic associated steatohepatitis. The terminology has been evolving. The standard of care has decided to change it to MASLD and MASH as opposed to NAFLD and NASH throughout the standards, because it is felt that MASLD or MASH better describe the disease process and are less stigmatizing. It's estimated that 70% of people with type 2 diabetes have MASLD, and that diabetes is a major risk factor for the development of MASH. People with type 2 diabetes are at increased risk of developing cirrhosis and hepatocellular carcinoma. MASLD is the presence of steatotic liver disease and at least one cardiometabolic risk factor associated with insulin resistance, like hypertension, hyperlipidemia, etc. Is someone writing on the slides? I see green.
I don't know how that's happening.
Yeah, interesting. Okay. It is formally diagnosed with MASLD is formally diagnosed with imaging, but having mild elevations of ALT and AST, where ALT is greater than AST, is suggestive of MASLD. MASH is formally diagnosed with a liver biopsy, where greater than 5% of liver cells are seen to be steatotic with inflammation. The goal of the FIP4 is to identify people who are at risk of developing MASH with the goal of preventing future cirrhosis, hepatocellular carcinoma, liver transplantation, and to reduce all-cause mortality. A patient can be developing liver fibrosis with normal liver enzymes. A value of less than 1.3 is considered low risk of having advanced fibrosis and for developing adverse liver outcomes. A score greater than 1.3 is considered as having higher probability of at-risk MASH, clinically significant fibrosis, and increased risk of adverse liver outcomes. A score greater than 2.7, we should be sending them to a hepatologist. So Maria's FIP4 was 1.73, which is greater than 1.3. The recommendation is to get a fiber scan. A fiber scan is an ultrasound that looks at the elasticity of the liver. She would be a good candidate for a fiber scan. This is what the fiber scan results look like. So they're separated into F0, F1, which is normal, F2 has moderate scarring, F3 has severe scarring, and F4 has cirrhosis. According to the algorithm, having a score of F2 or higher, which equates to that 8.0 kilopascal, I think is the measurement, an F2 correlates with that score. And if they have F2 or higher, they should be going to see hepatology. If they have less than that score, or their FIP4 is lower than 1.3, we can continue to manage. And we should continue to look at their FIP4s every 1 to 2 years. How should we think about treating MASLD in the context of diabetes care? So number one, weight management is key. There's consensus that a minimum of 5% weight loss and preferably 10% is needed to improve histology. Because of its value to help with weight management, GLP and GLP-1 GIP dual agonists are seen as adjunctive therapy to lifestyle interventions for weight loss in adults with type 2 diabetes, obesity, and MASLD. If someone has biopsy-proven MASH, the recommendation is to use pioglitazone or an incretin due to their potential benefits for MASH. And then combination therapy can be considered for treatment of hyperglycemia as well. If someone has cirrhosis, they should be seeing a hepatologist and to help us in the scheme of things with their diabetes care, because weight management and MASH pharmacotherapy we might not be using, we might be avoiding in that context. So I mentioned pioglitazone. Pioglitazone is not a medication we have been speaking about frequently. It is part of the TZD class of antihyperglycemics. Another drug in this class, rosiglitazone, was pulled off the market due to concerns of cardiovascular safety. Because of this medication, all these cardiovascular outcome trials for diabetes medications started. Pioglitazone is not rosiglitazone in terms of risk. So there are pros and cons to pioglitazone. It improves insulin sensitivity in liver, muscle, and adipose tissue. It reduces hepatic steatosis and inflammation. It slows fibrosis progression. It reduces stroke risk, especially those who've had a stroke before, and it's very cheap. It's $10 to $15. The cons is it can lead to weight gain. It's acting on adipose tissue as well, and so adipose tissue is going to take in more of that glucose. It can lead to fluid retention. There is an increased odds ratio of heart failure, although low, and there's also an increased odds of bone fractures in women. There's also a potential increased risk of bladder cancer, although there's a lot of conflicting data. We're going to have a talk more on MASLD and MASH and liver disease, along with retinopathy on June 13th. So I'm not an expert on these things. We're going to have some experts talk about them. But do any of you have any questions up until this point? Are there questions in the chat?
Questions in the chat currently, but if anyone has any, please go ahead and put them in there, or feel free to unmute and ask them out loud as well. Any age cutoff? Yep.
Yeah, there's no age cutoff recommendations for FIB4. You know, the way that I think about it is the difference in terms of my practice is using a CBC a little bit more frequently when I'm ordering my diabetes labs to get that platelet number. I would say that people that have had diabetes longer are at increased risk. People that are older are at increased risk. Okay, I'm going to move on. So we're going to talk about another case. John, he's 58 years old. He's had diabetes for 10 years, hypertension, hyperlipidemia, sleep apnea, elevated BMI. And he is coming in for his diabetes return visit. He also reports reduced energy and stamina. He doesn't have chest pain, but he notes having calf discomfort when walking long distances, which resolves when he is at rest. We get labs during this appointment, and I want to highlight his decreased eGFR of 58 and his urinary creatinine, urinary albumin creatinine 45. One of the new updates to the algorithm is the additional treatment options for those with chronic kidney disease. It specifically highlights that we can use SGLT2 inhibitors or GLP-1 receptor agonists with proven CKD benefit. It also says if A1C is above goal for individuals on an SGLT2, we can consider adding a GLP-1 receptor agonist or vice versa. Why is it adding this to the algorithm? Well, before I get to that, so this is how we classify chronic kidney disease. Many of you already know this, but just to repeat, we have two tools that help stratify a patient's overall risk of kidney disease, eGFR and albuminuria. John has an eGFR of 58, which gives him the diagnosis of CKD stage 3A, and his albumin level is 48, which is moderately increased. And overall, he has high risk of progression of chronic kidney disease. The new update to the algorithm is because of this study that came out last year called the FLOW trial. It was a randomized controlled trial that looked at patients with diabetes with an eGFR of 50 to 75. The intervention arm gave those patients 1 milligram of semaglutide subcutaneously, and the primary outcome was delayed progression of chronic kidney disease with reduced incidence of sustained decline in eGFR, end-stage kidney disease, or renal death. It found that there was a 24% reduction in risk of major kidney disease events. Now, this clinical trial had its share of issues that I think it is important to highlight. One, the trial was not powered to detect differences within and between important subgroups, like those with different severities of chronic kidney disease or different baseline characteristics. So people in this study had mild CKD. Their eGFR was 50 to 75. Two, at the time the trial was initiated, SGLT2 inhibitors and MRAs, the mineral corticoid receptor agonists, were not widely approved for kidney protection yet. As a result, the number of participants receiving these agents at baseline was modest. limiting the ability to assess the effect of combination therapy. 95% of patients in the study were on ACEs and ARBs. Number three, the majority of the participants identified their race as white, whereas chronic kidney disease disproportionately affects marginalized populations, including Black and Indigenous peoples. This limits the generalizability of the findings for these high-risk groups. Four, the effect on kidney function may not be generalizable to populations at different risk levels or those without type 2 diabetes. Although we might want to do that, the study didn't include those people. Five, there was high discontinuation rates for semaglutide. And six, weight loss associated with semaglutide could potentially lower serum creatinine levels, which might influence the results. This is a comparison between the SGLT2 inhibitors with benefit to reduce progression of chronic kidney disease, canagliflozin and pagliflozin and dapagliflozin, along with semaglutide. Now, these are not head-to-head trials, and the populations for each of these trials were a little bit different. So take the comparisons with a grain of salt. But I do want to highlight that the SGLT2 inhibitors reduce the risk more robustly for those with chronic kidney disease, while semaglutide does have improved risk reduction of cardiovascular death. So how do I interpret all this information? I plan to use semaglutide specifically in my patients with obesity and chronic kidney disease because of that added benefit for the weight loss. And we know that losing weight is helpful for their diabetes management as well. I'm more likely to use an SGLT2 inhibitor for chronic kidney disease benefits in patients with diabetes if that is the only variable. And then I may use them in combination if glycemic goals are not being met. There were a few more updates for chronic kidney disease in the standards of care in regards to blood pressure management. So we should be aiming for a target of less than 130/80 for blood pressure. And this received an A recommendation. We should titrate ACEs and ARBs to maximally tolerated doses for CKD and cardiovascular event prevention. And then 7 to 14 days after starting or adjusting one of these medications, we should be checking kidney function and potassium levels. We should avoid these medications in reproductive aged women without reliable contraception. There are safer alternatives like nifedipine and labetalol. And then we should aim to reduce urinary albumin by about greater than 30% to slow the progression of chronic kidney disease. There is not sufficient evidence to support lower protein intake for people with diabetes and chronic kidney disease. And this really fits into a lot of the things that we talk about with low-carb nutrition. People with chronic kidney disease and diabetes can have increased protein intake. The standard recommends protein intake of 0.8 grams per kilogram per day. And then the recommendation for those who are dialysis dependent is 1 to 1.2 grams per kilogram per day because of concerns of protein energy wasting for people on dialysis. So back to John, we talked about his new diagnosis of chronic kidney disease. His other concerns today was calf discomfort when walking long distances. And this brings us to our next point, which is peripheral arterial disease. 26% of people with diabetes have been shown to have peripheral arterial disease. Diabetes increases the odds of having peripheral arterial disease by 85%. 50% of newly diagnosed PAD are asymptomatic at time of diagnosis. And then we know that vascular screening for PAD is associated with increased pharmacologic therapy, reduced in-hospital time for peripheral arterial disease and coronary artery disease, and reduced mortality. The key here is thinking about how screening for PAD would change our management. For those with PAD, antiplatelet therapy should be started. And then our diabetes patients should be already on a statin, but it's even more critical if they have PAD. The standard of care recommends screening all individuals with diabetes who are greater than 65 years old with an ankle brachial index, as well as those less than 65 years old with additional metabolic risk factors like smoking, hypertension, dyslipidemia, and end organ damage like nephropathy, retinopathy, and neuropathy. So this is a synopsis graph about screening for cardiovascular risk. On the left side, you see coronary artery disease. We do not screen asymptomatic people for coronary artery disease. Last year, the standard of care gave a B recommendation to screening those for heart failure with a BMP. I'll be honest, I have not fully adopted this yet, but I do think it is a good idea for those with poorly controlled diabetes or if they had diabetes greater than 10 years. If the BMP is elevated, we can get an echo. And if they have heart failure, then we can treat with an SGLT2 inhibitor, which would help their diabetes and would help protect their, help reduce their risk of heart failure hospitalizations. And then here on the right is the recommendations for peripheral arterial disease that we just discussed. Okay, we have about another 10, 15 minutes. So I'm going to go over some rapid fire updates from the standards update. There are new recommendations for CGM use. The standards recommend considering using CGM in adults with type 2 diabetes treated with anti-hyperglycemics other than insulin to help achieve their glycemic goals. So fitting in line with our practice with MCT2D and the things that we've been trying to advocate for statewide with insurances, CGM is helpful for patients even if they're not on insulin. We see improved glycemic control. Studies show greater reduction in A1C for those using CGM compared to blood glucose monitors. And studies show that intermittent CGM use, so not every day, but 1 to 2 times a month, 1 to 2 times every 6 months, improves A1C. And CGM users saw more time in range and less time above range. Another study showed CGM use led to better self-management, reduced stress, and higher treatment satisfaction. Weight management updates. For those that are actively engaging in weight management treatments, we should be obtaining anthropometric measurements like their weight at least every 3 months. It also recommends aiming for a specific weight loss target of 3 to 7% weight loss to help reduce their risk of diabetes or help reduce their diabetes risks and have better glycemic control. Approximately 45% of people admitted for heart failure with preserved ejection fraction have diabetes. A study came out last year that supports the use of semaglutide for people with obesity and heart failure with preserved ejection fraction. So they didn't necessarily have diabetes. It found that people reported significant improvement in their symptoms and quality of life, as well as improved six-minute walk distance. For those type 2 diabetes, obesity, and symptomatic heart failure with preserved ejection fraction, it was recommended by the standards to use a GLP to improve their symptoms and physical limitations. So the standard of care updated the sleep section significantly, putting it on the same level as nutrition and activity in terms of lifestyle management. There are three different aspects to sleep: quantity, quality, and chronotype. Sleeping too little or too much increases the risk of type 2 diabetes uh, by 50%. Poor quality sleep, like having a sleep disorder, increases the risk of type 2 diabetes similarly by 40 to 84%, which is pretty broad range. And then having a late chronotype, so going to bed late, has a 2.5 times higher risk of developing diabetes. Poor sleep is linked to increased insulin resistance, higher A1C levels, and elevated cardiovascular risks. And improved sleep quality correlates with better glycemic control and mental health outcomes. You might be already discussing sleep with your patients, but it's important to think about it as part of the lifestyle improvements in diabetes care. You probably already have resources to help your patients with sleep hygiene, but sleep hygiene is an important thing to think about and potentially be utilizing more of these resources by associating your patients with diabetes with potential sleep issues. If you have time to think about screening sleep practices and sleeping disorders, it's something that I would recommend doing. I often will test my patients with diabetes for sleep apnea. The standard of care for the first time highlighted female sexual dysfunction. Over 33% of women with diabetes report sexual dysfunction, specifically decreased libido, decreased arousal, lubrication problems, and orgasmic dysfunction. Women are as likely as men to have sexual dysfunction, but are less likely to discuss it. It is often underdiagnosed and significantly impacts quality of life. So what should we do about it? We should understand that women may be hesitant in discussing their sexual health, and that many of us might feel uncomfortable as well with these discussions. So becoming more comfortable with it as part of our practice. And I think it's important to highlight that it is a significant issue for many. It is another topic to keep in the back of your mind. And the most high yield time to start the discussion about sexual dysfunction is during menopause or perimenopause. The standards also updated the section on men's sexual health. 52% of men with diabetes have erectile dysfunction. Testosterone levels are lower in men with diabetes and prediabetes. And erectile dysfunction can be a significant precursor or a significant sign of developing cardiovascular disease. The standard recommends screening men with diabetes or prediabetes with hypogonadal symptoms for cardiovascular and endocrine causes, including testing morning total testosterone. And then it says we should consider, for those with low or borderline low testosterone, testosterone replacement. I just think this is an important thing. Again, sexual health can be an important part of our patients' lives. We should be thinking about it. There's no direct evidence that doing testosterone replacement improves diabetes management, but it can be a source of sexual health concerns and potentially other symptoms that the patient may have. And so it may be something worth screening for. The standards created a new section about dental care in diabetes. Poor oral health, this was all new to me. Poor oral health is associated with worsened glycemic control and increased risk of diabetes, risk of complications. Diabetes increases the risk of periodontal disease and delays healing. And treating periodontal disease improves A1C by 0.5 point over 3 to 6 months. I found that to be fascinating. So the recommendations for us in primary care are to assess their dental health. That could be by making sure they're seeing their dentist at least twice a year, or paying attention to their oral hygiene during their physical exam. Letting the patients know that diabetes and dental health are important, and they should discuss their diabetes goals with their dentist so that they are part of the care team. Dentists should be knowing what medications the patients are on. They should be testing for hypoglycemia if there are any concerns in a dental visit. That's not for us to think about, but it's interesting that in the standard of care, they brought up this entire new section of dental hygiene and dental care. That's the whole presentation. I zoomed through that. Any questions? Feel free to chime in or add them to the chat.
Good afternoon. This is Dr. Mansudar. May I ask a question?
Absolutely.
Thank you. It's regarding the CGMs.
Yes.
So given the new guidelines from the ADA related to the benefit in individuals who may not be on insulin, are you seeing health plans potentially cover this like at a lower frequency of use for individuals that may not be on insulin? Or, I mean, is that something you're already seeing? Do we anticipate? I know it's hard to predict the future, but just asking.
So commercial Blue Cross Blue Shield will cover, should be covering CGM, even if they're not on insulin. This is something that we in MCT2D have really advocated for successfully. They should be covering it for our patients specifically, if you're an MCT2D physician. I haven't seen bigger uptake across insurances yet, but I think it's studies like these and recommendations like these that will hopefully make them a larger part of diabetes management in the future and have insurances cover them. But I haven't seen the change.
Yeah, and to add on to what Dr. Gabison is saying too, the insurers definitely look to the ADA guidelines as far as giving them information on what they should cover. That came up a lot when we have brought up CGM coverage to them in the past. They're like, well, when the ADA updates their guidelines, like let us know. So this is something that insurers use as kind of like a cornerstone of like their recommendations and what they cover. So like Dr. Gabison was saying, haven't seen changes yet. I feel like it was so soon that possibly they haven't really factored this into their decision making, but I do think it's possible as the ADA like backs this more, that more insurers will cover it more broadly.
And just to add on a little bit more, at a recent ADA clinical update, of course, this was highlighted, the addition of 1716. Consider though is important because it's upon recommendation based on randomized controlled trials. So that did come up at this ADA update, that's going to be the big swing for payers. So there was a call to action in terms of trying to get more randomized controlled trials, which are hard trials to do in this patient population, to try to spur these payers. So while I remain hopeful and will continue when I am meeting with payers to push this agenda, I also want to be realistic as to what really drives the payers.
Thank you. Just a follow-up question. Do you happen to have, as part of this randomized control trial, or any related evidence regarding the financial benefit of doing the CGMs in type 2 patients not on insulin compared to just random blood sugar checks, several times a week or that sort of thing?
I haven't seen financial information. I would assume that's where I feel like insurances should be taking this on a lot more, because if CGM alone is so helpful. That's cheaper than some of these medications, right? So I would hope that they start to see that, or a study would come out showing the financial benefits. But I haven't seen that data yet.
And to answer the question, I'm not aware of any clinical trials currently tackling this. So I think, again, that's why there was this call to action to try to get somebody doing this work.
I see Carl's question, does testosterone therapy have any effect on diabetes control? No, I do not see that. Projecting potentially if it helps with a lot of their symptoms, of fatigue, and energy level, and libido, maybe in the long run, it could help them with their diabetes distress and help them manage their diabetes. But there's no direct benefit to testosterone for diabetes control. And then Dr. Kathy Betcher asked, for the case of a man with diabetes and with CKD, would you maximize ACE prior to adding an SGLT2 inhibitor? I would say it depends on their glycemia or their A1C levels. I think definitely my goal is to maximize the ACE or the ARB, and to potentially add an SGLT2 inhibitor if they could use some improvement in their glycemia as well. If they're already maximized on ACE and ARB, I definitely would think about adding an SGLT2 inhibitor. Tiffany Jones asked, thoughts on rapid reduction of A1C with GLP-1 and retinopathy. Example, patient started on Mounjaro and titrated up once. An A1C dropped from 11 to 6.8. Provider was hesitant to increase dose due to rapid decrease, although patient would benefit from increased risk reduction with obesity. So bariatric surgery, starting insulin, GLPs, any medications or act that rapidly reduces blood sugars can lead to a spike in retinopathy. And so the general recommendation is to think about screening for retinopathy more robustly when we're starting some of these treatments. With the patient that you mentioned, I would definitely want them, I don't know if they were having symptoms, I would definitely want them to see their ophthalmologist. I may hold or lower the dose of the Mounjaro or the tirzepatide while things level out a little bit, and then in the future may decide to increase dose.
Thank you.
For the case of the man with diabetes with CKD, oh, I saw that one, sorry.
Any other questions from anyone?
Let's see. I've seen decrease in renal function with introduction of SGLT2 inhibitor or GLP-1 initially on a few occasions in patients who have CKD. And would you discontinue these meds if you see the decrease in renal function? How long would you wait before you say this is going in the wrong direction and need to discontinue? So, so that is something that can happen, especially with an SGLT2 inhibitor. I haven't seen it with a GLP. But definitely with a SGLT2 inhibitor, we can see a bump in eGFR or a lowering of eGFR, a bump in creatinine. I would repeat in about a month after we get that to see if it comes down. If it continues to be elevated or elevated more than 30% of what it started, I would probably stop it.
And Jonathan, if I could just add to that, from the CKD trials with SGLT2s, we know that that dip in GFR occurs within the first 1 to 2 months. And then we see the preservation of GFR hit after a year. So what I teach is that we treat SGLT2s similar to the way we treat ACEs and ARBs, and you know, stopping medication if there's 30% or more change in creatinine, but you know, we can expect this to happen, you know, 10-20%, and you just got to monitor. But again, to see the rebound going back up to preservation, it isn't until 12 months.
Thank you everybody for um, uh, bearing with the speed. I felt like I was going really fast there. There were a lot of things I wanted to cover. If you all have any questions, you can send them our way. I'm happy to answer more in the future. If there's any, I can stay on for another 5 minutes or so.
But yes, that's everyone's
I think that's it. I think we got all the questions.
Thank you so much, Dr. Gabison. Like we mentioned at the beginning, LIPA will be sending out the CME worksheet. We'll also send out the sign-in sheet for physicians who want to receive physician level learning community credit. And Dr. Gabison, are you okay with these slides being shared as is?
Absolutely.
Okay, perfect. Well, we'll send out the slides to everyone as well. So thank you again for leading today's talk. All right, have a great day, everybody.